Good evening.
Good
Hi.
evening.
Good evening, Jalil.
Good evening, sir. Srinivasan, sir. Good evening.
Neha
Good
ma'am,
evening, good
kindly
evening.
go ahead. We are live now.
Dr. Neha, you can start.
Good evening, everyone. Myself, Dr. Neha Singh, and on behalf of Maha IP as well as Raigad IP, I welcome you all to the journal journey 1st of June. Yes, today we are having our journal reading day, and it is on 1st of each month. I welcome Maha IP President Dr. Sanjay Pakmore sir, Secretary General Dr. Amol Pawar, State Convener Dr. Sanjay Deshmukh sir, Maha IP President 2022, Dr. Hemant Gangolia, Meenakshi sir, Raigad IP President Dr. Vikas More, Secretary Dr. Ajay Kohli, respected Dr. Neeman Mohanty sir, Jay Bhandarkar sir, Dr. Chitra Kulkarni ma'am, and all the respected executive board members from the Central IIP, Maha IIP, IIP Raigad, as well as other branches. I'm extremely delighted to welcome our esteemed experts of today, Dr. Mahesh Mohite sir and also Dr. Piyush Jain sir, to our journal journey, as well as our presenters, Dr. Sachin and Dr. Zenia. So now I invite Maha IP President Dr. Sanjay Pakmore sir to please give his blessings. Over to you, sir.
Thank you, Neha. Namaskar. Good evening, all the stalwarts, today's experts, presenters, and the moderators. And good evening, the office bearers of the Maha IP, our dynamic secretary, Dr. Amol, treasurer, Dr. Ravindra Sonone, Dr. Sanjay Deshmukh, as a convener, Vice President Dr. Pankaj Agrawal, treasurer, our auditor, Dr. Rishi Lodia, and our scientific chairperson, Dr. Minha Sheikh, sir, and all the Maha IP office bearers and all the CIP office bearers and the people who are joining regularly, Dr. Sareen and Dr. Srinivas, sir, and the person behind this program, that is Dr. Neeman Mohanty, sir, and the IIP Raigad branch. Frankly, this is such a program which gives the boost on the first day of every month. It begins the first. I mean, my tenure has begun with the first day, the first Jan, and that gives me the boost for the conducting the further 5 to 6 to 7 activities in a month. So it is after the end of the month, you remember there is a day on the first, whether it is a Sunday, whether it's a Maharashtra day or anything. But there will be a program called a journal journey, a very different type of program from other academic activities, where really the experts, presenters go through the journals, experts give their comments, and a lot of learning, lot of take-home messages. So it is a wonderful idea of Raigad IP, which I think last 4-5 plus years continued. I'm thinking in the future also it will be continued because it's such a beautiful program. Nobody can say it should be discontinued. So that's the beauty of this particular program. And then selecting the topics are such awesome topics. Every time one topic gives a newer concepts or newer perspective. Whether what the studies has been done and how in the day-to-day practice or in the current practice, it is how that study is viable. How it can be taken forwards. So I thank you, Raigad IP branch, for continuing this particular program, taking initiative and starting these programs and continuing for the last 4-5 years. Dr. Hemant Gangolia, sir, he was a past president, Maha IP in 2022. I think, and it will be continued in the future. And welcoming all of you on this Maha IP platform and wishing a good luck to the presenters, Dr. Sachin and Dr. Zinia. And I hand over the mic to Dr. Neha.
Thank you so much, sir, for all your appreciations. And now I invite Maha IP AHA's chairperson-elect, Dr. Chitra Kulkarni ma'am, to please introduce our experts and presenters for Journal Journey. Over to you, ma'am.
Please unmute, madam.
Yeah, good evening all. We are here with a very good topic and extraordinary experts for this episode. Our first expert for button battery topic is Dr. Mahesh Mohite, and he is doing exemplary work, very extraordinary work in Raigad area from last 30 years. Each and every serious patient from a periphery goes to him, gets admitted without any hassles, a smooth recovery, and what we get is positive feedback. He is student of Dr. Ambedkar sir, and he is teacher in council members of Critical Care Society in India, and he has given numerous lectures and awarded orations in various conferences. His extraordinary commitment to academics is well known during COVID times with online DIAP series. Welcome, sir. Our second expert, Dr. Piyush Jain, is a leading neonatologist in Navi Mumbai. He is DM neonato from KEM Mumbai and has taken advanced neonatal training from Melbourne, Australia. Welcome, sir. Our first presenter is dynamic young pediatrician from periphery. He is MBBS MD pediatric, running his own setup as My Child Care Hospital in Nanded. Welcome, Dr. Sachin. Our second presenter is very enthusiastic Xenia Poladia from Kamote MGM, and she has done such a nice work in her residency and bagged various awards and accolades. She is having research paper at this young age. Welcome, Dr. Xenia. Please stop sharing. Now may I request our first presenter, Dr. Sachin, to start his presentation.
Thank you, ma'am.
We request all our attendees to please post their queries in the chat box. At the end of both the presentations, we will be taking them if there is time. Thank you. Sorry, Dr. Sachin, you can continue.
Yes, ma'am. Good evening, all. Thank you, Maharashtra IIP and Nanded IIP for giving me this opportunity to present in this journal journey. Today, the topic for the discussion is button battery ingestion in children and their outcome beyond the esophagus. The authors for this article are Shrikant P. Kadayada, Jagdish Menon, Archana Siddhaya, and Ganam Aram. Original article is taken from Annals of Pediatric Gastroenterology and Hepatology, Ispagan, volume number 6, issue 4, October to December series 2024. The impact factor of this article is 2.937. Abstract of the study. The objectives were button batteries can be problematic, especially those who are lodged in esophagus. But however, there is a lack of data on outcome of button batteries ingestions beyond the esophagus. This study reports their experience from 2018 to 2023 with special emphasis on the outcome of post-esophageal button battery ingestions. Introduction to button battery ingestion. This is one of the common GI emergencies we are facing in day-to-day OPD practices. Button battery ingestion is common under the age of 5 age group. Out of that, 9 months to 18 months age group is very common because of pincer grasp is achieved at that time. Foreign bodies like coins, fish bones, metal hooks, clips, nut bolts, etc. we are seeing in the day-to-day practice. But few foreign bodies may be toxic and few may be non-toxic. These are common items where button batteries are found, like wristwatches, remote control keys, car remotes, calculator, thermometer, and laser lights. Esophageal foreign bodies is one of the emergent condition for endoscopic removal in pediatric gastroenterology OPDs. Button batteries can cause severe damage to GI tract, but few may require surgical exploration and prolonged hospital stay can be there. It depends on size, location, and time of exposure of that button battery exposure. In this pictorial diagram, I want to show most common sites of button battery impaction. First is cricopharynx muscle, second is aortic crossover, and third one is lower esophageal sphincter. Material and methods used for this study: retrospective and descriptive audit were done. Retrospective review of all button battery cases seen at Pediatric Gastroenterology Unit of Manipal Hospital, Hal Road, Bangalore. Few cases presented with telephonically, few patient presented with other branches of Manipal Hospital in Bangalore. Demographic details: need for endoscopy, spontaneous passage, time for removal of button battery, associated complications were also studied in this study. Size, location, and time of exposure were also studied. These are characteristic of children presenting to hospital with button battery ingestion. They are segregated according to the demographic findings, or like age, gender, weight of the child, symptoms at presentation in the outdoor patient, in the OPD, types of button batteries, sizes of button batteries, location of button batteries, and treatment given for that button battery presentation, need for endoscopy, need for further evaluation, those which are out of reach of endoscope, all were studied. Protocol for managing button battery ingestion. North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition guidelines were used for removing button batteries. Indications and techniques were assessed and reassessed for removal of button batteries. Esophageal button battery were taken up for endoscopy on emergency basis on an average time of 2 to 4 hours. Post-esophageal button batteries were observed for movement in serial X-rays, which was varied according to the ages and sizes of the button batteries. Immediate post-procedure management was the most important part in this. The X-rays findings or serial X-rays were taken after 24 hours, which is also again according to the age of the child. In less than 2 years, which was done in 12 hours. After 5 years, babies, or when sizes are more than 15 mm or less than more than 15 mm, then review X-rays were done in 24 to 48 hours of interval. If button battery location is not changed, then fluoroscopy was done to confirm the location of button batteries. And if it is out of reach of that endoscope, then observed with serial X-rays. Honey, sucralfate, like pH neutralizing agents were not used in this study. Few post-esophageal button batteries also get complicated, but no clear data to suggest the outcome and complications of button battery ingestions. This is diagrammatic presentation on X-ray appearance of a button battery. In first image, we are seeing that double ring appearance marked with that arrow, and in the second X-ray in B, that stiff off sign is visible. The mechanism of injury due to the button batteries. First, there is electrolysis, as the negative pole of the button battery comes in contact with esophagus, then hydroxide ions released, electric current is generated, pH is increased on negative pole, that causes alkaline caustic reactions and secondary mucosal injuries secondary to that. This was the protocol followed when witnessed or suspected button batteries were ingested, either esophageal or post-esophageal. If esophageal, patient is stable, then immediate endoscopic removal of button batteries. In esophageal foreign bodies, if there is active bleeding or unstable patient, Then endoscopic removal in operating room with cardiovascular thoracic surgeon help were taken. Evidence of nasopharyngeal injuries, where there is evidence of nasopharyngeal injuries or esophageal injuries, that patient get admitted, kept kneel by mouth and under cover of IV antibiotics. In those patients, CT angio and MRIs were done to exclude the aortic injury. If there is no significant injury, then before advancing, diet as tolerated were continued and observed. If injury is close to aorta, then patient again kept admitted, kept NBM under cover of IV antibiotic, and serial MRIs were documented. In button batteries, gastric location or beyond gastric locations, the segregation is around by age and size of button batteries. First is less than 5 years of age, and button battery size is more than 20 mm. Endoscopic removal within 24 to 48 hours, and to assess endoscopy within 24 to 48 hours to assess esophagus and to remove the button batteries. If there is evidence of esophageal injury, then patient were kept admitted, kneel by mouth with under cover of IV antibiotic and documented CT and MRI or chest X-rays. If child is more than 5 years of age and button battery is less than 20 mm of size, then patient is observed on OPD basis. Repeat X-rays were documented at the interval of 48 hours if button battery is more than 20 mm, and at the duration of 10 to 14 days if button battery is less than 20 mm. Endoscopic removal if gastrointestinal symptoms or not past stomach by repeat X-ray on follow-up X-rays were documented. This is the endoscopy visualization secondary to exposure of button batteries to the esophageal mucosal wall. In the first image, we are seeing the mucosal injury secondary to button battery. And in second image, we are seeing a large button battery in the stomach. Statistical analysis of the study, mean difference with standard deviation and difference in mean between the endoscopic removal and spontaneous expulsion group were tested. The percentage were tested using the chi-square test, and the significance level for all tests was set at 5%. Result, a total of around 45 foreign bodies were studied. Out of that, 27 boys, 17 girls with 47 ingestions. 2 of that were dual ingestions. The median range age according to this study is around 36 months. 5 button batteries were in the esophagus, and rest of the button batteries were beyond the esophagus. Among button batteries in the stomach and beyond, 14 underwent endoscopy, and out of that 14, 7 were removed, and rest 7 were observed with X-rays. A sub-analysis of post-esophageal button batteries were analyzed, like endoscopic removal versus spontaneous group, which was according to the sizes of the button batteries. The sizes of the button batteries were assessed in the either console room, through imaging, or after removal of the button batteries by endoscopic or surgical exploration. Size of the button battery emerges as the significant factor for forecasting the endoscopic removal and its complications. Injuries due to post-exposure button batteries were noted as early as 4 hours, but mean range of timing was around 4 to 24 hours. What is new according to the study? Nearly around 90% of post-esophageal button batteries pass out of the gastrointestinal tract without obvious complications and are expelled in stools within 24 to 36 hours. The rest 10% will remain in the stomach, requiring either endoscopic removal or surgical exploration. Now, we are seeing outcomes of post-esophageal button batteries. Outcome of post-esophageal button batteries in the stomach and beyond that, 14 went endoscopy. Out of 14, removed 7. The other 7 moved beyond the reach of endoscope, and there were documentation of no mucosal lesions, and subsequently they were observed. All of them passed through the GI tract uneventfully. Sizes, again, size and location was the most important factor. In a sub-analysis group, endoscopic removal or spontaneous passage group, Again, age of the child, duration to reach the emergency room after the ingestion of button battery, weight of the child, presence of GI symptoms like vomiting, drooling of saliva, hematemesis or melena, location and sizes of button batteries in were documented. After removal of button batteries, there were around 4 to 5 different sizes of button batteries were documented, like 11 mm, 19 mm, 20 mm, 21 mm, 23 mm, and 28 mm, where larger size remain in the stomach and therefore they required endoscopic removal. All were removed between 4 hours and 24 hours after confirmation of non-movement of the foreign body of the button battery or foreign body in the second radiograph. Though they did not document the time interval between the most recent X-ray and the endoscopic removal or endoscopic evaluation, but on an average, it ranged from 30 to 90 minutes. Conclusion of the study, nearly 90% of the button batteries pass the esophagus even in infants. Those beyond the esophagus, all small batteries of less than 13 mm pass out of the GI tract without complications. Larger diameter button batteries, more than 19 mm, are likely to be retained and cause injury as early as 4 hours of exposure. Like esophagus, the antropyloric region is the second most common site for injury after the esophagus. Post-esophageal button batteries retained in same position even after 12 to 24 hours is an indication for removal. On an average, that removal time is 6 to 12 hours in infants less than 1 year of age group. Now, impact of button batteries beyond the esophagus, secondary complications like GI bleeding, perforation, fistula formation, vascular complications, and peritonitis. Take-home message from this study and awareness. Parental awareness is the most important to prevent button battery ingestions. Early emergency room visit to either pediatrician or gastroenterologist. Explanation of warning or danger signs to parents. Display of objects and precautions for button battery ingestions at camps or OPDs. Avoidance of toys or objects containing button batteries which were otherwise unnecessary. As an awareness program, ISPAGAN observes on 12th of June of every year, International Button Battery Awareness Day. They displayed one chart which was labeling the common items, those containing button batteries, how to be button battery safe. They have provided the helpline numbers in case of emergencies. Following were the references which were taken for the study. Thank you.
Thank you so much, Dr. Sachin. It was very nice presentation and the slides were good. The delivery was also good. Now may I request our expert, Dr. Mahesh Mohite, to give his expert comments. And
Okay,
again,
Sachin.
the questions will be answered later on.
Sachin, can you stop sharing the slides?
Yes, you
Yes,
can.
sir.
It was absolutely wonderful presentation. First of all, let me congratulate you for taking this very important issue, which is least discussed, but very important. Very,
Thank
very
you, sir.
important. And there are no clear-cut kind of a guidelines till this date, perhaps. Okay. And this study is very recent one. Perhaps in 2024 it is published.
Yeah, yes, sir.
The study conducted period is 18 to 23. So 5 years. Though we call it as very often, many times this is a referral work which we get it. Why we are so worried about this? Obviously, for the simple reason that chances of necrosis. We have ourselves seen perforating alkali batteries causing mediastinitis and strictures and long-term complication when it is stuck in the esophagus. And that is how so far we are worried only about the esophagus. And that's how 2 years ago the ESPAGAN guidelines had come that if it is stuck in the esophagus and if you don't have a immediate modality to remove it, then that's where you said that honey and all those things, and that's evidence based. That till the time you can remove it, keep on giving honey about 5 ml every 1 hour and try to get it out within first 4 to 8 hours. Don't allow it to be there for longer duration. Otherwise, that electric current burning, they call it as liquefaction necrosis. The typical term used for that pathology is liquefaction necrosis, wherein they will just burn that whole tissue and it can perforate into the mediastinum. There are injuries known even to the aortic arch of the aorta and massive perforations and death due to that. It's very dangerous thing. there is no doubt about this foreign body being stuck in the esophagus, which need to be removed immediately. It's absolutely no doubt. Question arises when it goes beyond that, what to do? And there was no answer to this. Gastroenterologist used to say that you can wait up to 2 to 4 weeks. But that was a general rule for other foreign bodies, metal foreign bodies, which we can allow them to come for 2 to 4 weeks. But in case of alkali batteries and all, the same rule cannot be applied because it stays there for 12, 24 hours. It's going to play its own role. So I recall, in fact, last week only we were discussing on a Raigad group when child was referred with a coin, which was stuck initially for 3 X-rays back to back. The first X-ray showing in the stomach, second X-ray also showing nearly in the stomach, and third is around the same place. And this child was referred almost after 20 days. And now what to do? Actually, when I saw the X-ray very carefully, I realized the position, those looking around stomach, the position had changed drastically. So the third X-ray, which was taken about 2 days ago, actually it had reached the colon. So when he came to me after almost 21 days, I said, let me take one more. And by that time, it had come into the rectum. So it was about to be passed. What I mean to say, just a X-ray may not tell you all the locations, especially if you take only AP X-ray. Always, even in the stomach, you take it a lateral X-ray also, because it might have gone beyond stomach and it may be already in the transverse colon or maybe in descending colon, where sometimes the overlap position cannot be recognized just via AP X-ray, and you may have to take a lateral X-ray also. As far as from the study point, I wanted to know how many of these patients they had to do the exploratory laparotomy to get the battery out. You mentioned 5 of those 47 were in the esophagus and they removed. So somewhere around 40, 41 had gone beyond that. And then you said 10% had to be removed and 90% passed off. So obviously now none of them required exploratory laparotomy. So is there any guideline when we should go? So like suppose it has gone down right in the ileum or something, it's now not accessible to your scope. Then is there any
Mohanty sir, can you pitch in? Mohanty sir,
when we should go ahead and explore this child?
please unmute. Yeah,
Thank you,
yes.
Dr. Chitra.
Yeah.
No scope. Actually, nobody nowadays considers exploratory laparotomy because we have scopes available. Beyond in esophagus is very dangerous because if it leaks, as Dr. Boita has already said, necrosis occurs very fast. And while removing, unless you are careful, the edge of the coil or the butter battery can damage the wall of the esophagus and goes to the perforate and get a medicinal leak and may damage the out of also. So that is an issue. But they are not that panic when it is beyond the esophagus. So in the stomach, you can remove it by endoscopy, it's fine. But if it goes beyond then it's not very much necessary. Otherwise, the colonoscopic removal is also possible if it passes through the enterocolon junctions. So there is no literature to support to the exploratory laparotomy, and I would suggest that apart from that, you can choose fluoroscopy is also will be better. Only to positioning fluoroscopy you can monitor double contrast fluoroscopy you can do. If it comes down to this colon, there is no problem. But in the intestine, they say it will not cause any harm there, but it should be removed faster.
The reason I asked is I have a couple of cases from our own collection, and of course they were not battery, but there was a metal kind of a coin. Okay, it was a coin, which was definitely a coin, not a battery, from the history also. But problem is now this coin did not come out even after 3 weeks. Okay, how long to wait was a question. And we were taking serial X-rays every 3 to 4 days. Unlike the butter battery where you are supposed to take X-ray every 12 to 24 hours. And if the battery don't move in subsequent 2 X-rays, then there is a very clear guideline that we should go very aggressive and get it out. For the
Yes,
simple
yes.
reason being, why it is not moving is very important. Especially in that case of coin, which we saw the coin almost stuck almost in the fourth week, and gastroenterologist decided to go aggressive. A slightly bigger child, about 4 years old, and now the scopes can reach even beyond duodenum and right up to, from the other end they can go up to ileum. And they noticed there was a ileal narrowing at one point of time, due to which it was stuck. And then if it is a button battery, then that can create a disaster if it is stuck at some point of time. So every 12 to 24 hours, take an X-ray, even if it is beyond the esophagus or even if it is beyond the stomach, and there is no change of position after 24 hours, then one should seriously think of going surgically and getting it out. Though none of the cases in this series are said, but there are case reports wherein because of this one single reason, they had to go very aggressively and get the battery out. Otherwise, subsequent, if it perforates and causes peritonitis and strictures and all,
Yeah, yeah.
that's a disaster. It's very difficult to manage. Especially, I have faced a case of mediastinitis due to perforation of this battery in the
Yeah.
esophagus. That to
Minash
Very
manage is
serious.
very, very difficult.
Very
Minash
serious.
sir wanted to ask something.
Yeah.
Dr.
Yeah.
Minash, please.
Yeah,
Yeah,
Minash.
good evening. Thank you, ma'am. At the outset, one must compliment the way Dr. Sachin has presented his
Absolutely.
presentation.
Absolutely.
I mean, this is one of the finest presentation that we have seen. Clean presentation and a composed expression. That's number one. Thank you, Dr. Sachin.
Thank you, sir.
Then, couple of things. It's interesting to note that 90% of the button battery has been naturally expelled, because button battery has always been a real cause of concern to most of us. And as Sir Mahesh sir has rightly said and Mohanty sir has said, one of the important thing is leaking. Once it leak at any point of time, be it stomach, be it beyond that, be it esophagus, be it beyond that, we are worried. That's number one. So this is, this is reassuring with regard to this scientific paper. But I think the message is that button battery, we have to be very careful. That's number one. Number two, as Mahesh sir was telling, there are certain, whether it is button battery or non-button battery, there are certain areas in the GIT where there are always chances of getting stuck up. So for one of the important is second part of duodenum. So suppose it passes beyond that, then another part is ileocecal junctions. So if from these areas, if it is gone, then a little bit reassuring, particularly non-button battery. Button battery at any point of time, we are worried about the leaking, and that is what we have to be careful. I think though it is 90% which has expelled at its own, but the message is that we have to be very careful. Need not be going for laparotomy always, but have to be very careful clinically. This is my take from it. Thank you for that.
Thank you. The rest of the chat box question we will discuss later on. May I invite the second presenter, Dr. Zenia? And the topic is infant colic revisited.
Chitra madam, Dr. Devendra sir wants to have a question. Let's have
Okay, sir. Devendra
couple
sir,
of questions
please.
because it generates interest.
Yes.
Yeah.
So, first of all, congratulations, wonderful presentation. We appreciate. And sir, the thing is, endoscopic facilities removal are not available in the rural peripheral areas also. Suppose a pediatrician is there, then what are the guidelines how we should manage that child till he refers to the higher center like that, sir? Any precautions to be taken by him, supportive treatment, anything special in this case?
Dr. Sachin, you want to take it? You tell
Sir,
and then I
Mohit
may
sir,
take over later.
yeah,
Dr. Sachin, you
Mohit
want
sir,
to
you can
say?
answer.
In case it is
Okay.
as per this, if there is an indication to remove, this should not be delayed. It should be earliest sent to a gastroenterologist where scope facility is there. We cannot take chance in this. The button battery can leak and cause permanent damage, sacaturation also. A lot of complication later on. So it should be sent to the nearest scopy center or the expert as soon as possible. This message should be going to our general pediatricians. Not only we know for reassurance the parents, one way it's all right to watch this, but if it's delayed beyond 24 hours, we should send it to some center where facilities are available.
But sir, supportive treatment, any guidelines till the patient reaches to the center? Sometimes they are remote areas, na? Then only pediatrician is there and nursing staff like PHCs. Then
There is
what?
We have to watch for the
Just-
obstetric features, if any,
No.
and they keep on feeding this baby at least liquids. This should feed the baby. Dr. Mohite is going to say.
Yeah. So basically, Dr. Sarin sir, if you don't have facility to remove, irrespective of where the foreign body, and if you're sure it is alkali battery, you better refer it. Because whether this child is going to require intervention or not, we definitely don't know. Even it is a 10% risk, why to take it? One thing. Secondly, if you happen to see it in the esophagus, then there is a clear guideline from the ISPAGAN as well as Indian things to give honey 5 ml every 1 hourly till you remove it. That honey will coat the foreign body, supposed to be coating the foreign body and prevent the electrical discharge and avoid the damage till the time you remove it. And this is evidence based. This is not Ayurveda, homeopathy. This is
Yeah.
allopathic recommendation to give honey 5 ml every 1 hour till the time you remove it. So you better start that and send the patient, because if this stuck in that, if you decide
Six
that
cycle.
after 8 hours, you already missed the bus. And if it goes into the stomach, you're lucky if it passes through. If suppose it gets stomach, usually going to take a X-ray again after 24 hours. Suppose it is there itself, then again it's going to be required. So that 24, 48 hours not worth taking risk, especially in case of alkali battery, corrosive poisonings, those kind of patient, I feel it's very difficult to manage, because in corrosives also, you need to do a scopy after 24 hours to see the things, and scopic insertion of feeding tube and all. So corrosive poisoning and alkali battery, two things I'm really scared. We don't have facility to send it ahead and let them take a call according to the
Yes.
management part.
Very right.
Yes,
Thank you.
Sachin.
Thank you
Sachin
very much,
wanted to
sir. And shall we
Doc-
move to the second
Dr.
topic
Sachin
now?
want to say.
Sachin
Last comment
wanted
from
to say
Sachin.
something.
Yes, ma'am.
Okay. Okay, Sachin.
Dr.
Yeah.
Sachin wanted to say something.
Yes, ma'am.
Yeah.
Nowadays, even at periphery or in taluka places, in government hospital or in private hospital, imaging or chest X-ray or X-ray erect abdomen is easily available. As per the history of parents and warning signs, as I have mentioned, is omitting, drooling of saliva, history of hematemesis, or toxic patient, nature of the patients, its clinical signs and symptoms, worry of the patients. All this will tell the severity of the disease and time of exposure. Usually in peripheral areas, most of the times parents usually they get early presentations as foreign bodies, as babies with foreign bodies or small babies. Usually there were attenders along with the babies. But in urban population, most of the times family person or close attenders is not always available with the kids. That's why in rural areas with foreign bodies, there is early referral. One, nowadays there is X-ray erect abdomen or X-ray chest is easily available even at taluka places. And third important thing for referral is signs and symptoms and worry of the parents. The severity of signs and symptoms is early referral. We can't wait like other foreign bodies in button battery injections. Button battery injection is always an emergency unless and until it is documented that size and documented the site or impacted location of the button batteries. Irrespective of that, button battery injection is always an emergency, at least in peripheral areas.
Agree.
Thank
Thank you.
Thank you,
Thank you.
Sachin.
Yes, sir. Mohanty, sir.
Yeah, next.
Shall we proceed?
Yes, please.
Yeah. Dr. Zenia?
Yes, ma'am.
Yeah, please share your presentation and start.
Ma'am, is it available?
Yes, is visible.
Good evening, a very good evening to all the stalwarts and experts of IAP. Today I will be discussing a review article, Infant Colic Revisited, which has been written by Dr. Nimain Mohanty and Dr. Rimjim Srivastava. It was published in the Annals of Pediatric Gastroenterology and Hepatology 2024.
To begin with, infant colic, it is a behavioral symptom complex which is seen in around 4 to 28% of the infants under 3 months, characterized by excessive crying and fussiness without any identifiable clinical cause. It lacks standardized diagnostic criteria, hence posing a challenge for both clinicians and parents. The definition. Firstly, there is a Wessel's rule of threes, which defines infantile colic as crying more than 3 hours per day, more than 3 days per week, and for more than 3 weeks in a healthy infant. There is also a Rome 4 definition, Rome 4 criteria, which was published in 2016, which describes it as an unexplained, prolonged, inconsolable crying and irritability in a well thriving infant under 5 months of age, which is unrelieved by the caregivers. The diagnosis. The diagnosis requires symptom onset and resolution within 5 months with recurrent unsoothable crying that is reported by the caregivers. The infant must be otherwise healthy with no fever, growth failure, or identifiable medical cause. For the purpose of research and survey, the definition focuses on a shorter observation period, like 1 week or 1 day, and uses a structured tool like interviews or diaries. This differs from the regular definitions, which requires symptoms over several weeks and are based on general caregiver report. The crying duration and quality. Brazelton tracked the crying pattern in around 80 infants. The crying increased until 6 weeks with a peak of around 3 hours, that is 2.75 approximately 2.75 hours per day, and then declined by 12 weeks to less than 1 hour per day. The common symptoms included persistent agonizing crying with irritability and restlessness. Parents perceived it as colic, often describing the cry in very vivid and distress related terms, though there was no clear cause ever identified. The clinical presentation. On examination, the child will present with a tense abdomen, clenched fist, flushed face, the knees drawn up, passage of flatus, and there will be no relief with feeding or consoling. The crying episodes often cluster in the evening with sudden onset and abrupt resolution. The baby will appear normal between the episodes. Most infants outgrow it by 3 to 4 months. Excessive crying may reflect parental perception as well, especially among first time or anxious parents. So it is important to rule out the basic needs of the baby, whether there was hunger, overfeeding, discomfort, or desire for attention. Moving to the family perception of a crying baby. If the baby becomes quiet after its demands are met, the parent and the baby can be hospitalized in selected cases to observe and assess the family perception, to distinguish what is true excessive crying from a normal infant behavior. So, to evaluate feeding, sleep, the bowel habits, and the daily routine. Also, what should be considered is maternal anxiety, whether she's a first time mother and the inexperience she could have as a first time mother, and the family support that is lent. There are no laboratory tests to confirm the diagnosis, so hence it is the perception which often shapes the concern. Conditions that mimic the infant colic. Symptoms of infant colic are often misattributed to gastroesophageal reflux disorder, cow's milk protein allergy, or lactose intolerance, especially if there are loose stools or flatus passage. Always rule out common causes like recent immunization, local infections, diaper rash, insect bite, or any anal fissures. The baby should be evaluated for serious conditions in the eye, ears, gastrointestinal system, the genitourinary tract, muscular system, or any musculoskeletal system, or any hidden injuries. The important red flag signs that need to be watched for should be vomiting, poor weight gain, lethargy, fever, abnormal neurological signs, or respiratory symptoms, which indicates all these red flag signs, otitis media, they indicate that the child needs further workup. An algorithmic approach to infant regurgitation. If there are more than 4 regurgitation episodes per week, lasting more than 2 weeks in an infant that is aged more than 3 weeks to less than 6 months, warrants an evaluation. So first, we need to assess the feeding technique, the frequency, and the volume. If it is associated with irritability, vomiting, arching, cough, or failure to thrive, then we have to consider beyond the physiological causes. So first, we start with reassurance and burping if otherwise the child is well. If the symptoms persist, then we can give a trial of thickened, extensively hydrolyzed formula for 2 to 4 weeks. If the baby shows improvement, then we do a milk challenge test. And if that is positive, then we have to manage the patient as a cow's milk protein allergy case. But if there is no improvement, then we should consider cases like gastroesophageal reflux disorder, eosinophilic esophagitis, or structural causes, and then refer the patient to a pediatric gastroenterologist for a specialist opinion. Moving to etiology. As per the current evidence does not support any definite organic cause for the infant colic. The common assumptions like GERD, the allergies, malabsorption, they lack proof. Tests like stool pH, reducing substances, alpha-1 antitrypsin, occult blood, and even the breath hydrogen test offer no diagnostic value. Colic incidence is similar in breastfed and formula-fed infants, making dietary protein hypersensitivity unlikely. Functional colic remains a diagnosis of exclusion with no identifiable trigger in most cases. Other etiology, the colic may also result from early life enteric nervous system dysregulation leading to gut hypermotility. Motilin, which is a motility regulating peptide, is elevated in colicky infants, independent of the feeding type. There is ghrelin, which increases the motility and appetite and is also elevated in infants with colic pain. There are pro-inflammatory cytokines, such as the macrophage inflammatory protein, monocyte chemotactic protein, interleukin 8, and tumor necrotic factor alpha, which cause higher intestinal permeability and hence have been observed to be elevated in patients with in the colicky babies. Colicky infants also show biochemical signs of inflammation and altered serotonin metabolism, along with a disrupted gut microbiota. Fecal calprotectin is increased, indicating a low-grade intestinal inflammation. The gut microbiota differences are that the colicky infants will have fewer lactobacilli, affecting the short-chain fatty acid production and the gut health. Non-colicky infants will show more lactobacillus acidophilus. The colicky infants also have higher levels of lactobacillus brevis, lactobacillus lactis coliforms, and there are potential pathogens like E. coli, Klebsiella, Pseudomonas, which are seen as early as the first week of life. The management. Cognitive behavioral therapy is the primary approach. So the parents need to be counseled on the benign and the self-limiting nature of colic. They need to be reassured that the crying episodes cause no long-term harm. The family has to be encouraged to share the caregiving to reduce the maternal fatigue and promote increased physical contact between the mother and the baby. Other supportive strategies like reducing tactile stimulation, keeping the baby in a calm, quiet environment with some dim lighting to avoid any loud noises or any strong scents. Use gentle soothing techniques like swaddling, lullabies, or maternal massage. There is something known as a white noise, which basically mimics the womb sounds that helps to calm the baby. And to promote exclusive breastfeeding for nutrition, bonding, infection prevention, and to improve sleep, which may reduce colic. Feeding strategies. To prevent aerophagia by burping the infants upright after feeds, you use appropriate teeth size and collapsible bottles for the bottle-fed babies. A Cochrane review in 2018 analyzed around 15 randomized controlled trials with around 1,121 babies. The primary outcome was the reduction in crying duration, and the secondary outcome was the response to intervention, the crying frequency, and the adverse effects. A study of 90 infants was done comparing maternal hypoallergenic diet versus the usual diet, of which 74% infants whose mothers followed a hypoallergenic diet showed reduced crying to less than 1 hour per day after 48 hours. Only 37% reduction in infants of mothers in crying was seen for mothers on usual diet. So typically, eliminating common allergens such as, say, dairy or eggs, nuts, wheat, soy, seafood from the mother's diet had shown benefit, and it just supports the dietary modification as a potential intervention in breastfeeding mothers of colicky infants. There was another study with 21 infants comparing the dietary changes alone versus dietary changes combined with parental counseling. The crying time was around 2 hours per day for those on hydrolyzed or a dairy or soy-free maternal diet alone, but had reduced to half, which is around 1 hour per day, when the parents also received 9 days of counseling, which highlights the crucial role of parental education in improving the treatment outcomes. For oligosaccharide plus the hydrolyzed formula versus a standard formula with simethicone. A study with 267 infants comparing partially hydrolyzed formula with oligosaccharides versus the standard formula with simethicone. So the crying duration reduced significantly more in the hydrolyzed group, and the standard formula group showed not a very significant reduce from 5 hours to around 3 hours. The difference remains significant at 2 weeks. So partially hydrolyzed formula with oligosaccharides significantly reduced the the crying time compared to the standard formula plus simethicone. The benefits sustained over 2 weeks, highlighting the efficacy of formula modification in colic management. There was another study of 19 infants where where soy protein versus standard cow's milk protein formula was compared. The mean crying time in the soy group versus that of the cow's milk. So around 5 infants responded. 5 out of 10 infants responded to those that belonged in the soy group versus none among the 9 infants showed any improvement that were given the cow's milk group. So no study evaluated the parents or the family's quality of life and their satisfaction or the infant's sleep duration. Partially hydrolyzed low lactose formula with oligosaccharides reduced the infant's crying time more effectively than the standard formula with simethicone. This benefit is sustained over 2 weeks as well, supporting the formula modification in colic management. The ESPGHAN committee, the soy-based formula lacks any proven benefit for colic and hence are discouraged in early infancy due to potential risks. So the current guidelines recommend avoiding soy formula in the first 6 months. Pharmacological agents. So simethicone. Simethicone lacks any proven benefit and the safety data in young infants showing no advantage over the placebo. Simitropium bromide, though showing some effect, is not approved for pediatric use and hence requires caution before use in children in the pediatric age group. Simitropium plus dicyclomin, they carry significant risks and hence are not recommended for young infants despite limited efficacy. It has side effects such as respiratory depression, apnea, and drowsiness. Also, similarly for dicyclomin, which has also shown no recommendation as such for the use of dicyclomin, which has also showed risks like drowsiness, coma, apnea, dyspnea, seizures, asphyxia, and hypotonia. Herbal remedies also have shown no proven benefit and may pose serious safety concerns. The balghutti that normally parents come to the pediatric clinics asking for whether it should be administered to crying babies. Sucrose may briefly reduce the colic pain, but the effects are short term. Lactase and proton pump inhibitors, they show limited or conditional roles, with proton pump inhibitors only proven for use in gastroesophageal reflux disorders, but after the dietary measures fail. Use for probiotics in infant colic. There is strong evidence that supports Lactobacillus reuteri for reducing colic, especially in breastfed infants. Probiotics offer a very promising and a safe intervention for both prevention and treatment of infant colic. Lactobacillus reuteri significantly reduces crying in breastfed infants with colic, and the efficacy in formula-fed babies, however, remains unclear, warranting more studies. The ESPGHAN supports probiotics like Lactobacillus reuteri DSM for breastfed infants after parental counseling. Parents should be informed about the colic nature's course before opting for treatment. Traditional and alternative treatments of colic, they lack scientific evidence and safety data. The common remedies like herbal tea, fennel oil, gripe water, good tea may often have harmful substances like alcohol or opium. Risks include drowsiness, feeding problems, gastritis, a potential for future dependency. Even manual therapies like chiropractic, osteopathic, or acupuncture are not proven safe for infants and hence should be avoided. The long term sequel. Infant colic mostly resolves by 4 months with no known long term complications. While colic generally resolves without any lasting effects, there are some studies that indicate potential risks for behavioral and functional issues later in childhood. A UK study suggested persistent early crying may be linked to hyperactivity and academic challenges at 8 to 10 years. And there was a 10-year prospective study that found higher rates of recurrent abdominal pain, allergies, and functional disorders in children who had a past colic history. Hence, our take home message is to emphasize the importance of careful history and exam to exclude any serious cause by ruling out the red flags. Investigations to be done only when clinically indicated to identify any underlying pathology. To promote exclusive breastfeeding and avoid unnecessary formula changes to prevent failure to thrive and maternal distress. The maternal avoidance of known allergies in the diet has shown to help, which should be advised. Cognitive behavioral therapy is the mainstay, because there is no proven pharmacotherapy available. To avoid unproven alternative treatments and manipulations in the vulnerable group, probiotics like Lactobacillus reuteri and B. lactis have shown promise. However, further evidence is required before routine use. Reassuring the parents about the benign and self-limiting nature of colic and that most cases, around 90% infants, are effectively managed with parental education, counseling, and strengthening the parent-infant bonding. This is a summary of how to work up an infant when they present with excessive crying. If the infant is less than 5 months old with excessive crying or fussing, firstly, they can be observed and observe the baby and the parental behavior after hospitalization. If there are any red flag signs, if the child is having weight loss or failure to thrive, then the child needs to be referred to a pediatric gastroenterologist to work up and evaluate any underlying organic cause. However, if there are no red flag signs, no weight loss, failure to thrive, we need to elicit if there are any psychosocial problems in the family, any poor feeding technique, maternal exhaustion, a poor family support, there is poor parental bonding. If yes, then they need to be counseled accordingly. If not, then we need to evaluate further whether the child is formula fed. If the child is on formula feeds, then the mother and the family needs to be advised proper burping and to try to change to a fully hydrolyzed formula. However, if the child is not on any formula feeds, then we can try to eliminate allergens from the mother's diet, advise correct feeding technique and burping, consider Lactobacillus reuteri for 3 weeks after discussing with the parents about the self-resolving condition of the patient. Thank you.
Thank you very much, Dr. Zenia. It was a lucid presentation. And may I invite our expert, Dr. Piyush Jain, sir, for his expert comments?
Right.
Can you please stop sharing if you want, sir?
So first of all, I would like to congratulate Dr. Zenia for a wonderful overview of infantile colic. As we all know regarding this infantile colic, colic per se, although it's a benign and self-limiting condition, and we all know by at the end of 3 to 4 months it's going to stop, but it causes a lot of anxiety, especially to the young parents, and especially in urban setting where most of the time it's a nuclear family. And as far as if we see the vessels and the room 4 criteria where they mention the diagnostic criterias, including more than 3 hours of crying. So as we all know, in an urban setting, we know nobody will wait for a baby to cry for more than 3 hours in a day, and they will rush to hospital much before that. So practically, what as a clinician, what we have to see is as soon as the baby arrives and the parents are anxious, try to evaluate in detail. Like you have to check each and every baby's organ before labeling it as a benign colic. Just evaluate each and everything, which Dr. Zenia already mentioned, right from head to toe. starting from the any signs of meningitis, then in the ear otitis media, then in the eyes any evidence of conjunctivitis, mouth oral thrush. Similarly in chest any signs of pneumonia, LRTI, abdominal volvulus interception. So right from head to toe, try to rule out before labeling it as a benign infantile colic. That's number one. Number two, always once you are sure that no baby is otherwise healthy and okay and it's just a colic, still you have to counsel the parents that you have to show the parents that baby is growing well, baby is otherwise okay. Then only they will understand that yes, it's a benign condition and we should not worry. Otherwise, they will keep roaming. They will go to some other doctor. Before, they will always think that there is some another disease which we are missing, or there is a chances that the young mother may can go in some postpartum depression kind of thing. So that is very very important. Always check the growth of the baby. Try to plot it on a growth chart always, so that that gives a visual impression to the parents that yes, baby is growing well. That means there is no major problem. There is certain characteristic features of colic like paroxysmal onset. So baby was absolutely okay. Parents will say baby was absolutely okay and suddenly start crying. Baby was sleeping and suddenly started crying. And similarly, the stoppage is also abrupt. So crying stoppage is also abrupt. So that is a classical feature of colicky symptoms. And obviously hypertonia and flushing that you have already mentioned. Regarding causes of colic, nobody knows. So there is some role of feeding malpractices, some role of gut inflammation, which you have already mentioned, and some microbiota alterations. So, but all these are speculative, and nobody knows why this colic is there. So difficult to say and pinpoint. Some role of cow milk protein allergy and lactose intolerance, but again, no clear-cut guidelines available. Regarding management, you have already very well expressed that we should not directly jump to any pharmacologic or any single medicines. Always try to counsel the parents first. Cognitive behavioral therapy is the best and the easily doable thing in the routine OPD practices. And try to explain them that it should resolve in next 3 months, 2 to 3 months, and then on an average you can ask them to maintain a diary if they are too anxious. So day by day they will see that the crying time is decreasing. So all these things you can do. The role of lactobacillus reuteri is coming up, but again it's not FDA approved, I think, so far in the first 6 months. So we cannot directly jump on this medicine for each and every colicky babies. So far, uh, good parental counseling. If any faulty feeding, sometimes we have seen that baby is underfed and that's why baby is crying. So you have to ensure the growth parameters and see whether baby is passing adequate urine. That give you fair idea whether baby is just a hunger cry or it's really a colic like symptom. So that's all from my side. Over to Dr. Mohanty sir for
Yes,
any
we are
further
very
expert opinion.
fortunate to have the author of this paper,
Yeah.
Dr. Mohanty sir, over to you.
Yes, sir. If the nature
Thank
colic,
you. I think Dr. Puladia and Dr. Jain, they have covered the topic at length. Only I can add that some hypothesis towards the etiology, because in misnomer, the one hypothesis is that the maturity of gut is lacking. So all the babies gut do not mature same time. They take longer time. Some babies. Then another concept is coming the internal nervous system, the crosstalk between the gut hormones, or say gut and the brain. Gut brain crosstalk is defective. So for small pains, they perceive the pain exaggerated manner. Some babies, which is not normally not felt so in other babies. So only no medication should be used. That is the what not to do, to be told to the parents repeatedly, then what to do. This colic aid and very aggressively lactase is being marketed in our area also. Lactase in a oral form, if you give, lactase is effective when there is a lactose intolerance only. Lactase is at the tip of the villus in the duodenum. But if you are getting lactose through the orally, the entire thing will get digested in the stomach with the stomach acid. There is no point in feeding those things. It's misnomer. It's not that lactose is not effective at all. The endogenous lactase and this lactase are totally different. You need not, it's a placebo. So similarly, no medications is advisable. Others are harmful, and the liquids which were giving the gripe water were giving in rural areas very common. Baby go to sleep, and because many of the products I have seen there is a percentage of alcohol also. For that effect, baby goes to sleep and parents feel happy. My baby is because of this liquid only. The baby is sleeping nicely. So all the herbal therapy, the traditional medicine. So any daima or see either own grandmothers or doctors in our family itself, they have remedies. This should be by and large avoided. If there is a difference, you should find out GRD with this kind of infantile colic. Many of us we jump to prescribe the PPI, lansprozole, whatever it is. This should not be given at all. This GRD actually starts maybe little late, with 4 months of age, but it goes on till 5, 6, 9 months. But this infantile colic will stop at 4 months. If it is persist beyond 4, 5 months, it is never infantile colic. You have to differentiate. Maybe a GRD. You have to. A history is very, very important. How the baby cries. Baby cries more clustering towards the evening, and total duration of 3 hours is not at a stretch. The baby will cry over a period for the whole day, maybe in different spells. If a total duration may be 3 hours, it is not to be adhered very strictly. 3 hours, 3 times in a 3 days in a week, or at least 3 months. So these are they were defined very 1951. So it is not no longer valid nowadays. The in GI disorders like in functional GI disorders, FGID we say, these are a group of problems with pain abdomen syndrome. We have a chronic pain abdomen children, recurrent pain abdomen children, but we are called functional when they start beyond maybe 4 months, 4 years. We term is functional when no etiological factor is identifiable. Before 4 months, we do not label it functional because before toilet training is achieved, this should not be labeled as functional. So this is one type of functional pain abdomen, maybe in a very early age, maybe going in the future, may land up in that kind of a category. We don't know. So best not to do anything, observe the baby and rule out any underlying organic cause by appropriate minimum investigation. That's all. Thank you.
Thank you, sir. Dr. Jalil Ahmed, sir, has raised the hand. Sir, your comments, please.
Madam, this is excellent presentation, and it is most important clinical scenario which is always a disturbing to the practicing pediatrician, number one. And the question to Sachin sir, once the button battery ingestion is witnessed and subsequently it is missing, then you assume it is being ingested. In that aspect, you proceed the further thing. And the second question is, if the size of the battery and the contents is differ as long as the symptoms are concerned. The second one for the infantile colic, we never prescribe any medication. And since it has been well addressed in the ECD program, The responsive caregiving is a very, very important thing you have to teach. If there is an absence of grandmothers and grandparents, if they are IT fellows, then it is always a difficult to convince them also. They consult before coming to us, the auntie, Google auntie, and disturb them. So just a responsive caregiving and the position, and you have to follow that 5 years. That's my comment. Thank you, madam.
Yeah.
Srinivasan sir. Srinivasan sir. Chitra madam,
Srinivasan
Srinivasan sir
sir.
wanted
I
something.
have been a national lactation counselor and this thing and trainer. So we have conducted more than 57 day and this thing workshops. And this infantile colic, when before this, we have been no, we were giving dimethic, but change of environment. Those days when the hammock was used in caring for the children, these colics were not occurring because constantly the child is being rolled in the hammock. But it has become a modern this thing, and of course it's a very frustrating problem for parents. So now after this thing, there are three positions given where the mother is taking the child and keeping the child close to her abdomen and from head to this thing, cervical region to this thing. And I have done this so many times when even from abroad they had called me and asked me. Then I have sent these three pictures which is there in the manual, IOCF manual. And if it is properly done and also methodology is given. So the father also can do. It's not that either the child is made to lie down prone in the lap of the mother and she gently brings the hand from cervical to buttocks region and gives a massage like this thing. Okay, and it's very helpful. And most of the people whom I have sent messages and the photograph and the steps, they immediately within 2 days they have mentioned the problem has been settled. I think no medicine is necessary. After this particular training program, we are following this. We have never given any medicine and change of environment. The child is suddenly taking to the area, open space where there is lot of breeze. The child becomes all right. So I agree that medicine is not a very important this thing management. Only thing I can, of course, this picture is there in that IOCF manual which has been brought out, and all the steps are also given. And we have been doing this, and after this we have never prescribed any medications for infant. It's a self-limiting condition, as mentioned by everybody, that it is passing phase. Okay.
Yes, very nice, sir. That kangaroo mother care is also helping, no, along with this.
Yeah, that's true. Yeah.
And the role
Any-
of the maternal diet, sir, maternal diet, what Dr. Kumbre has also asked in the chat box, role of the
No,
mother's diet.
yeah, if too much of this thing spicy food is given or this thing taken, or sometimes these things may matter. Yeah, we have to find out the reason. So what is this thing? Yeah.
Yeah.
So
Even too much
usually
of
the
coffee intake, too much of
Yeah,
coffee
well,
intake
fine.
or tea intake more than the usual, or very spicy food, sometimes, not always. We cannot blame the mother every time. Yeah.
Yes, but Campa is having its role, no? Your Mohanty sir, your
My
comments about soya milk and Campa, cow milk protein allergy and soya milk, you had highlighted that.
No, it's irrelevant because soya milk is not prescribed earlier than 6 months. So in
Yes.
infant colic, they disappear by 5 months, 4 months. So
Absolutely.
this soya is not relevant. When these some people they try hypoallergen diet to the mother, so they say mother may be advised soya diet instead of hypoallergen food. But this there is no proof, and the baby should not be given soya milk before 6 months. The European guidelines, American guidelines say. But there are certain compelling situations in India. I had a talk with Dr. B.R. Thapa, PJ Chandigarh. So he started using that at 4 months, 3 months soya milk when there is, of course, the CMPA. Soya milk, they say ki in our country, we don't see much of soya allergy like the USA people they see. Ours being a poor country, we do not consume their industry product like purified the milk products. They have the industry
Hydrolyzed formulas. Yeah.
hypoallergen formulas. we can't afford. So soya they have tried, and in a controlled manner they have given to hospital children. They did not find an allergic or serious problem with soya milk given earlier than 6 months. So that is that we are not recommending that. I am telling the experience only.
Yes.
So that's about soya.
Yes. Further questions,
Just,
Dr. Neha?
Wish
just
Mohitte
one
sir
comment.
want to add.
Yeah,
Shmohit
just,
has
Yes, sir.
raised
yeah, yeah. So basically now it's a very, I mean, this is a perfect crowd to introduce this topic. Okay. So, Dr. Srinivasan sir is in medicine for last almost 70 years. Mohanty sir is for 50 years. Myself and Hemant and maybe Dr. Jalil and Dr. Askar for almost more than 25 to 30 years. And there is younger generation with I mean, Piyush Jain for 20 years. And Zenia will be passing in another 2 years. So you can see in 70 years, our understanding of colic has not changed. We are still lingering, searching for the exact cause. We need to understand it's a multifactorial problem. It's not just one single factor, but perhaps since it almost unanimously closes at 4 months, Dr. Mohanty sir's perception and thinking or that philosophy that probably it's a developmental pathology of the gut, and that's what I convince my most of the patients that probably gut is developing. You don't expect the child to start jumping from the second day of birth. Similarly, let the gut also introduce kind of recover, and another 4 or 5 months. So by when he comes in the second month, and I say 4 or 5 months, I have bought those 2 months of peace for myself and for the patient. And what I've seen is a proper counseling for 15-20 minutes with a gray hair or no hair on the head of the pediatrician. That's the only way to convince and counsel them that wait for some time. And all those newer modalities, Campa and hydrolyzed formula, these are all, believe me, many of them are industry-driven researches. Let us be very honest about it. It's a industry-driven researches. So let's not fall prey to that, and let's follow what we feel. Most important, avoid any, check thoroughly for any red flags. So you may call the child again after 1 week, 2 weeks, ensure the weight gain is good. As Piyush said, draw the growth charts, show them the growth charts. Okay, sometimes your counseling itself helps a lot. So rule out those red flags, counsel them many times. And believe me, my patient of colic rarely comes for colic again after another 1 month, 2 months. Rarely, because at first visit itself, I take a good peaceful 15-20 minute with him, and they are convinced. So I think that's most important. Good counseling, some kind of senior advice. And here, those dadima and all are many times very influential. So take them into confidence. The poor mother also gets into confidence. It's only time, counseling, confidence, some time, and most important, get that growth chart right. Avoid those CMP. I've seen suddenly that market of hydrolyzed formulas and CMP diet and all has gone up. I mean, where I would not 2 cases of CMPA, and I see the prescriptions which are coming loaded with CMP diet. It's really very ridiculous. I don't know what happens to those mothers. Very tin, the poor mother, I don't know where she gets it. So let's refrain from those practices. This is a recoverable, almost recoverable, self-limiting, benign condition. Let us convince it ourselves first. Then we'll be confidently able to convince them to the relatives and mother, and that's the story. Let's not the research. I don't think we have any answer. Time will come where we may have some multifactorial onset and we'll have precision medicine. AI is coming to take your place by that time. So be happy till the time AI is not entering in this field.
Gut brain
Again,
axis.
I am insisting on the responsive caregiving, and it is always the presence of elders, and it is a very valuable support for the baby. And one question to the Sania, whether is this linked to any later problems like ASD, madam? Those baby experience frequent spells of infantile colic. There is a literature stating that there is a link between the behavioral issue and the
ADHD.
autistic
Yeah.
spectrum.
Yes.
Just a comment on that.
Piyush Jain, sir, ASD and yeah.
Literature wise, there is no evidence, sir. It's a self limiting disease, resolves by 4 months, no long term complications. The long term, what they have found is the colicky babies, their families, they have found long term that some family disharmony and those things, and those babies are more colicky. Some studies showing it's a sign of early migraine. So some babies may have later on migraine-like symptoms. Otherwise, ADHD, I did not find any study correlating with that. It's a benign condition. Probably just rule out other red flags, and that's it. If it is a pure colic condition, no problem. Baby will be all right by 4 months.
Thank you, sir.
Wonderful presentation, and I would say both the presenters have done the justice, and wonderful expert comments by both the experts. And I always start with the beginning. To have a child, it needs a sacrifice. They start complaining on the day one only when the baby cries in the night hours. I said the cycle is there for the next 3 months. Now you have become a parent. Now you have to keep sacrificing for your baby sometime, and in that also lies a lot of satisfaction and happiness. So I think, as the sir Mohit sir has said, the good counseling at the first encounter with the parents, and great advice by sir, both Srinivas sir and Mohanty sir, taking confidence, especially the elderly people, nani and dadis. Your job is well done. You have done the job best. So getting their confidence and getting them into them confidence, and this you learn by after graying. Once your hair gets graying, in the beginning of the practice, you're rather tempted to prescribe something, but as the days goes, your prescription becomes narrow and narrow, and ultimately you don't write any medicine and you move towards counseling. I think that is the lesson the time tells us when we see the lot of patients. So great, and great learning from you, all of you, sir.
Yeah. Dr. Neha, questions from chat box?
Yes, ma'am. Most of the questions have been already mentioned, but they're repetitive question about the calculation of the size of the battery and about the use of honey and sucralfate, their quantity and how many times should be given.
Yeah, it is answered in the chat box only. Dr. Sachin has
Yes,
already
but-
answered
Sachin has
about
answered
those
already.
questions
but
in
for
chat
the
box.
audience, the audience who
We
So they can access
want
to that.
more elaborative answer on sucralfate. May I request expert or Mohanty sir? Sucralfate, is it that safe?
No, we don't recommend sucralfate. Honey, yes, honey is
Honey
recommended.
has been recommended, honey. Easily available also.
Yeah.
Sucralfate is recommended. It's there in the literature also, almost
Ispagan.
same dose as honey. Ispacan has given honey and sucralfate both options. Dose is almost equal, same 5 to 10 ml every about. In case of sucralfate, it's slightly prolonged, maybe every 2 to 3 hourly. In case of honey, it's every 1 hourly, 4 to 5 doses. So by that, they expect you to get the battery out within first 4 to 6 hours. Don't allow it to be there beyond that time.
Sir, even if it is impacted in the esophagus?
No.
You are
Will not
confirmed
move.
it is impacted. There is no rule of sucralfate then, I think.
No,
If it has
no.
past the esophagus, gone in the stomach, then
Yeah.
you can go for sucralfate.
No, if it is in stomach, still no role. It is
Acha,
only if
no
it is in
role.
esophagus. You are coating
Oh.
it. Once in the
Acha.
stomach, there is no role.
Okay.
Yeah.
Dr.
may I
Minash Sheikh sir, do you want
yeah.
to add something? Your
So
comments, sir?
I think this was expected that both the topics were of great clinical importance and the practical importance. And I think it is almost 25 past 10. We have surpassed our time, and if we continue to discuss, we'll continue more and more. So I think we
Yes.
conclude with the thanks and the last comment from Dr. Heyman, and we conclude for the next month. Over to Heyman, sir.
Thank you. Both were very practical topics, and I expected there will be a lot of questions, and for that. One most important thing is, and probably Dr. Srinivasan sir has said, change of environment. In my practice, I say, जब भी जास्ती रोने लगा ना तो इसको आप बाहर लेके जाइए, रूम से बाहर
Yes.
निकलिए और
घूमने
बाहर
चले
जरा एक आधा घंटा घूमिए बच्चे के साथ, बच्चे को घूमना है बाहर जाकर, and it works. I think so. It works
It
for that.
works.
Then another comment or other things I want to say. There's a lot of, as already said, grandparents are there, and mother and father and all Google and everything is there. So best thing, and about a maternal diet. The only interesting interesting query which I feel always, whenever we prescribe drugs, we always see whether there is secret in the milk. So whether it is food also, anything, any element of the food which comes in the breast milk and causes this. Of course, it may not be scientific, but if that is the only just way of counseling, then what I say to mother, if your in-laws feel you should not eat this, ठीक है ना, sacrifice for 3 or 4 months, don't eat. What difference it will make? There are a lot of food to eat. So that is another way of counseling. So counseling is major. Then interesting thing which I want to say is about Woodward's gray water. Of course, we always attach a tag of group gray water that it contains opioid. It doesn't contain opioid. What it contains, original gray water contains 3.6% of alcohol. And now the gray water which is there, it is just contains the Saccazira, that seeds is there, which is maybe chemically it is a sodium bicarbonate and some sugar particles. Just to information, I am not recommending, I am not saying that it should be, but just for knowledge, because sometimes patient asks. So I just, for the knowledge purpose, we always see it is contains opium and that it doesn't contain. And now it doesn't contain alcohol also. So it is just some oil and just some sugar and some sodium carbonate. And to end, excellent presentation by both presenters, excellent things and really practicals, which we can really implement in the practice. Thank you very much.
Neha, can I
Minasex,
come
sir?
in?
Yeah.
Yeah.
Yes,
Next
I think we
one
should
topic.
yeah. I think whether you take it as a vote of thanks or whatever, but I must compliment a couple of people. Number one, the Riger team, which has been consistently performing this particular J&J since last 4 years. So right from Mohanty sir, Chitra madam, Hemant sir, Neha Ganguly and all, that's number one. Number two, the Maharashtra IIP led by Dr. Sanjay Pakmode, Amul Pawar and everybody. They have been kind enough to continue J&J in the year 4. And one of the important things I must highlight is that we have the excellent presenter, so also the excellent reputed experts. I mean, getting Dr. Mahesh Mohite sir and Piyush Jain on board is not that easy. So we must compliment their presence there. So also the presenters, including Dr. Anewar, he has actually, one thing which we have found in the Maha IP is that we are getting good speaker from the areas, like distant areas. So Anekar was excellent, Anewar was excellent, our Zenia was too good. And so also the presence of seniors and stalwart that like Jalil sir, Srinivasan sir, Devender sir, till the end. So we acknowledge their presence. We acknowledge everybody's presence and the team, backend team, including Pallavi Dharmadikari, for being with us always. And we meet you again next month, 1st of July. And I must tell the last thing, that whether it is Sunday or the holy, not holiday, holy. We had a J&J on the day of Holi. So this represents and reflects the consistency and performance of the entire team. Thanks to one and all. We meet again next month.
Yeah,
Thank
sir,
you.
our next one
First
topic
Jali
is
is a doctor's day.
Minasek,
Doctor's Day, the 1st July.
Journal journey started on the 1st of July 2021. So it will be the fourth birthday, completing 4 years.
Very nice. Very
Wonderful
nice.
job. Yeah.
So many
Absolutely
days.
commendable.
Information, our original article of hyponatremia in acute encephalitis syndrome in children, Indian Pediatric 2025 article will be our 1st of July original paper, and the second one soon Dr. Minasex sir is going to put it in the group. Thank you very much.
Thank you, sir.
Chitra madam.
1st July will be Doctor's Day, sir. Doctor's Day.
Yes. I said that only.
Yes.
Chitra madam,
Maharashtra Day, Doctor's Day,
madam,
Holy
enjoy.
Day.
Chitra madam, we acknowledge the presence of Ramakant Patil also.
Yeah,
Yeah,
and Dr.
and
Bhaskar.
Dr. Arkala
Please, Ramakant
Bhaskar,
Patil.
our
Yeah,
organization
Ramakant kidhar hai?
chairperson is also
Please,
there.
Ramakant, it's pleasure to see you.
Kute
Welcome,
Ramakan,
sir.
I would.
Welcome, Ramakan.
Here,
Aye.
Yeah.
Me Ramakantla
Sir,
purposefully we did
please
not
unmute
darshan
and you
dya.
can talk few words. Dr. Ramakant Patil as well as Dr. Arkala Bhaskar was there.
Yes.
I'm really fortunate to have them on the board here.
Ramakan sir, darshan dya. Yes, Dr. Arkala. Yeah, Dr. Arkala. Dr. Bhaskar, please.
Yes.
Sir, good evening,
Dr.
everybody.
Good
Bhaskar,
evening,
please.
sir. Good
Yeah.
evening.
Good
Good
evening.
evening,
Dr.
sir.
Good evening.
Thank you for giving me this opportunity. This very informative, though it is a common topic, very informative, sir, especially for the practicing pediatricians. And this infantile colic, though it is not an life-threatening, but it is an emergency for the parents. And most of the times, what we observe is once they reach the hospital, the child stops crying. So we advise them, as one of the sirs said, just roam out in the evening. So thank you, sir. Thank you. Very excellent talk, sir. Thank you.
Ramakant sir, if you're
Ramakant
there,
Patil, sir.
I think he left.
yes. No, he's there, but probably he's
Yeah,
not.
yeah.
Yes. Chalo.
Thank you, sir. Thank
Okay.
you for
Thank you. Thank
joining.
you.
And the formal vote of thanks was to be given by Dr. Neha Singh. Over to Dr. Neha.
Thank you, ma'am. So after listening both the experts and seeing both the beautiful presentations, I would like to say that relying on a single approach limits our perspective. So embracing diverse solution leads to more effective and adaptable problem solving. So today's we had an excellent session of journal journey with good articles selected by Niman Mohanty sir, wonderful audience and excellent expert and speakers. I would like to thank both our experts, Dr. Mahesh Mohite sir and Dr. Piyush Jain sir, for accepting our invitation for being the expert for today's journal journey. Your guidance and expertise comments were very helpful and informative. Very thankful to Dr. Niman Mohanty sir, Chitra Kulkarni ma'am for doing all the hard work behind each session of journal journey, right from selection of articles, presenters, and finalizing the presentation. I would like to thank our MAHAIP President sir and Secretary General for giving us their support, and MAHAIP platform, also Raigad IP President and Secretary for equally supporting the program. Would like to thank the presenters of today, Dr. Sachin and Dr. Zinia, for preparing and delivering their articles fantastically. Really, both presentations and the articles were very nice. Thank you, Pallavi ma'am, for all the technical support, and I would like to thank all the attendees on Zoom and YouTube channel for joining us today. So requesting all to please join next month, 1st of July, Dr.